Well, hi everyone. Thanks again for coming to today's seminar. I'm very delighted to introduce our speaker and our fellow colleague, Robab Abdulkhani, who is presenting a PhD completion seminar to us today. And as someone who has recently completed the PhD process, this is a very exciting milestone in this long journey. Robab is a PhD candidate at the Centre for Digital Transformation of Health and the Department of General Practice at the University of Melbourne. She's also undertaking a fellowship by training at the Australasia Institute of Digital Health and has recently joined the Victorian Committee of PIDH. Robab merged her knowledge and expertise in two fields of health information management and consumer health informatics to develop new knowledge about reliable management and use of health wearable data in clinical practice. So today she'll be presenting on the guideline development for data quality management of patient-generated health data.
All right, thanks Dawn for the introduction, and hi everyone, and thanks for joining us in this seminar. Before I begin, I'd like to acknowledge the traditional custodians of country throughout Australia and recognize their continuing connection to land, waters, and community. I pay my respect to them and their culture and to elders, both past, present, and emerging. Today, in this completion seminar, I'll be presenting my PhD research about connecting wearables to healthcare through a guideline for the quality management of patient-generated health data, and I hope you find it interesting. As you see, this project comprises 4 components. It developed a guideline to say how the quality of patient-generated health data collected from health wearables can be managed in remote patient monitoring initiatives so that this data can be reliably used for patient care and be incorporated into routine clinical practices. Different people look at data quality differently. If some of you would expect to see some formulas on how to calculate the accuracy of algorithms embedded in the wearables or designing a wearable platform, I'd say none of this will appear in this presentation. It focused on data quality management concept from health information management perspective, which means looking at data quality across all data management stages from collection to use in decision making. Also, the scope of this project was limited to the quality evaluation for use of pghd in patient care and not about secondary uses of this data. Let's start with pghd portion, which is also called person or patient-generated health data or mobile health data that refers to any type of health-related data such as health and treatment history, symptoms, biometric data, lifestyle choices, and other information that created, recorded, gathered, or inferred by or from patients and their caregivers to help address a health concern. Today, the explosion of connected health tools market, including both medical grade and consumer grade wearables, and their associated tools such as apps and portals, is helping in high production of pghd. This new technology is not only helping patients to better understand their personal well-being, but also arming clinicians with a more complete patient profile and the ability to be proactive in their care. Remote patient monitoring initiatives are one of the solutions to help bridge the gap between pghd, wearables, and healthcare industry. Although RPM was primarily used to manage chronic conditions, the COVID-19 pandemic is already accelerating the use of these initiatives to treat mild cases of diseases. For example, some clinicians are using data from a wide range of wearable devices to monitor patients who aren't enough to be hospitalized. But remote monitoring will continue to play an important role during and after the pandemic, especially given the limited capacity of acute care facilities. However, successful remote patient monitoring relies on high quality data and efficient data collection and management process. But what's the current situation of remote patient monitoring? And to what extent it consider the quality of this data? And what's the role of data quality management in these programs? how the quality of pghd might contribute to the safety and the quality of care in these interventions, to help in integrating this source of data into clinical workflows to be reliable for use in shared decision making. So this project tried to find answer to these questions. This is how a daily life of a diabetic person, Steve, looks like when he uses a wearable and communicate the data with the clinicians to better manage his diabetes. Diabetes was one of my 3 cases, but because of being the most complicated case, I've chosen an example of it for this presentation. Steve uses insulin pump with a receiver to adjust his insulin dose, as well as a continuous glucose monitoring or CGM that connects to a mobile app and give real-time information and alarms on the blood sugar. Also, he gets weekly or monthly reports on a patient portal that he can share with the clinicians. He writes down his activity and meals on diaries. Additionally, he uses glucometer a couple of times a day to calibrate his CGM. Also, he has a fitness tracker to monitor his activity and heart rate and other data. But this watch can't be connected to the CGM to pull all this data together in one platform. So to monitor his status on a daily basis, he has to be careful on doing the calibration, taking notes, changing the sensors, injecting insulin, and all this sort of stuff. So take a moment and think about the quality of all pghd that automatically and manually captured in this scenario, and how it might impact the safety and quality of his health monitoring. Why should we care about pghd quality? Because these data are distinguished from the clinical data that captured inside clinical setting. First, the person and not the clinician is the primarily responsible for collecting this data, and he or she is doing it outside the clinical environment. And they may share it through different social platforms with others. And also, there is no guideline exists to say how this data, the quality of this data should be managed. I should say that the concept of pghd was defined by the US Office of National Coordinator in 2012, when they came up with this specific phrase for mobile health data. This picture simply shows how remote patient monitoring scenarios work in Steve's case, as well as others who use wearables for monitoring different diseases. Data might be collected manually or automatically and stored in an app or portal that's mainly administered by the wearable vendor. Then, based on predefined protocols for that remote monitoring intervention, the person brings the report at the clinic visit or share it remotely between the visit via emails or phone calls. At the clinician side, when they review and make a decision or a shared decision with a person, the PDF report is saved in a folder somewhere in clinician's computer, not being further analyzed in the EMR. And this process of data management is similar in different remote monitoring is applied for different health conditions. But to what extent the clinicians would consider the quality across the collection to transmission to review and use of this data? And what do we exactly mean by quality? It's actually about whether these data are complete, accurate, understandable, accessible when needed, and relevant to the condition, and how all this might impact the safety and quality of remote monitoring. Some clinicians might say the quality is not that much important because they're happy with the report. It gives them a sense of what was going on, and that's it. Some may say they trust the device because it's already regulated in terms of accuracy, and that's it. But quality is not limited to the accuracy nor the device itself. There are other issues that might impact the quality of pghd. The behavioral issues around the person himself, the family members or caregivers, the process in which data are transmitted, and the technology. If still remote monitoring seems to be okay in terms of quality, why would these interventions be limited to one-off short-term small-scale clinical studies and not be incorporated into routine clinical workflows? Can the quality be one of the barriers? And why does no guideline exist that specifically talks about pghd quality in these programs? Whereas we have established data quality management guidelines used within healthcare settings for the clinical data. Maybe because remote monitoring initiatives are still at the early stage of adoption. So in this project, I tend to understand how data are managed in remote monitoring, how the quality is monitored during data management, and what socio-technical issues might impact them. The output was a guideline that was developed based on identification of challenges, solutions, and expectations of pghd stakeholders. Following the guideline development process, which includes the stakeholders' involvement, guideline documentation, finally its validation, I did this project through 5 qualitative studies. We're going to spend a bit more time here. Obviously, I started with the literature review to identify the gaps in this topic and found very few papers that address clinical use of pghd, which somewhat spoke about data quality. Through this study, I defined some themes for data quality management related to pghd and the socio-technical issues that might impact them. As all of you know, there are traditional guidelines, as I mentioned earlier, that exist for clinical data. So I did a review of those guidelines as well to make sure that the identified themes in the literature or the aspects for data quality management of pghd are not missing some important areas. Among those guidelines, I found the one developed by Australian Capital Territory Health is more comprehensive. So I adopted its definitions for this project to have an evidence-based tool for the next step. So I used 7 aspects of data quality management for pghd, including accuracy, accessibility, timeliness, consistency, interpretability, completeness, and relevancy. Then for the second study, I used the tool to interview some pghd stakeholders to understand what's going on in different remote monitoring contexts, how pghd is managed, how its quality is measured, and what challenges these folks are facing in terms of data quality management of pghd. Let me mention some of the challenges I had, especially during this first empirical study. The most challenging thing was to find participants. I realized that remote monitoring lacks presence in different primary, secondary, and tertiary care settings. I first tried to get information from health information professionals in any type, like CXIOs, health informaticians, or even health information managers, whose one of the primary tasks is data quality management and medical records. But actually, they had no information about these programs, which means they are not even involved in the team. It wasn't like you call a specific department and get all the information about remote monitoring, like for what disease they're running them, what wearables are used, and so on. So I had to always ask people around me, share a call for participation through various channels, grab some hospitals and call every individual clinic and ask them if they are implementing remote monitoring. Likewise, I called some of the wearable vendors here in Australia to know which healthcare setting is partnering with them. It was really time consuming. But I finally interviewed stakeholders in 1 primary care, 1 secondary care, and 5 tertiary care settings in Victoria and New South Wales that were running remote monitoring for different chronic conditions like diabetes, sleep disorders, and cardiac arrhythmia. I'm not going to go through the details of the findings here. I'll explain them later on in the next slides. During that time of doing the interviews, a report published by the US Office of National Coordinator for Health IT that mentioned two pilots tried to integrate PGHD with EMRs and facilitate the use of them in clinical practice. I did interview with folks from those two studies and see how they consider PGHD quality. At the same time, another work was released in the UK that I approached those as well. Then in the third study, I brought the identified challenges into a participatory workshop with participants from Victoria as several PGHD stakeholder groups to discuss potential solutions as well as realize what they expect from each other to be able to efficiently practice data quality management of patient-generated data. At this stage, my team and I felt the topic is becoming much clearer for us and for the participants. But it was only one study with a limited number of participants. In the future, more co-design studies need to be done to explore this topic from different PGHD stakeholders' perspectives. In the fourth study, I further synthesized and interpreted the findings from the first three studies to translate the identified gaps, challenges, and expectations into a guideline. Finally, the guideline needed to be validated to see how it could be important to the safety and quality of remote monitoring programs. Using a Delphi method via an online survey, I selected 10 health information management and health informatics experts around the world, mostly academics who were known for their experience and knowledge in data quality management or in PGHD research. Interestingly, the participants rated all of the recommendations provided for data quality management of PGHD as essential to the safety and quality of care, and no recommendation was rejected. That's why I stopped the Delphi method to the first round. So this is the whole process of guideline development and validation through multiple qualitative studies. This is a snapshot of the guideline. My whole PhD output is summarized in this one page. And now let's briefly explain each aspect of those 7 aspects of data quality management of PGHD. I'm going to start with accuracy. It's defined this project as when data are free from errors. The first thing was about device calibration. Some wearables needed one-off calibration before starting data collection. But can we ensure it works correctly in the entire data collection period? Some others required calibration a couple of times a day throughout the data collection. But even for those devices, I found the advices on how often and when to calibrate is not based on clinical standards of care. Usually patients get what's recommended by the wearable vendor, but few clinicians who seem to work in these programs for a long time, they disagreed and wanted these to be based on clinical advice. Also, it's still taken manually, which might be with some errors. So this guideline suggests that calibration be done automatically to whatever possible and be based on standards of care. Also, some PGHD elements like meals, mood, still need to be entered manually, which might not be accurately captured. But for those of data who can be collected automatically from consumer wearables such as activity, heart rate, and other general wellness data, why should the patient still need to enter them manually into a medical wearable? Because there's no mechanism exists to connect consumer and medical wearables data together. The third item is annotation of either manual or automatic entries, which is absent in most wearables platforms. It would help to correct some inaccurate data immediately. The second item is PGHD accessibility. Some wearables are blinded, don't show raw or processed data to the patient or to the clinician during data collection. Some are deliberately disabled because of clinical purposes. But interestingly, the same devices showed data to the patients at data collection in other cases of the same disease. Some research studies showed that new generation of wearables that let patients access their data once they capture them would engage them in their health and help in changing the behavior if needed, and to move from passive to active participants in remote monitoring of their health. And the same with clinicians. Some wanted to get access not only to the process data in the report, but also to the raw data to find out some more details. The second one is getting routine notification on pghd access by others, which I think highly depends on defining pghd ownership principles. This might be more suitable to the patient. The third is dynamic consent. Most patients were not satisfied with the single click on the terms and conditions of the app in the wearable platform or the consent to get from the clinic. Rather, dynamic consent for different levels of access to the data is needed. pghd timeliness, which focuses on time of accessing data. Still, no protocol exists to define data availability on an ongoing or periodic basis in remote monitoring of one type of disease. For example, some wearables of the same type are blinders, some others show data during data collection. Some clinicians can only get the report at the clinic, some get it remotely. I found some people don't even call it remote monitoring because there is no remote interaction with the patient. Whereas most clinicians reported that if there would be a mechanism to share data in real or near real time, they would notice some issues and identify the causing habits and behaviors rather than relying on the patient's notes that might be forgotten. Let's see what consistency has to tell us. Still, most pghd, whether in consumer or medical wearables, don't have clinically accepted definitions or standardized formats. Each wearable has its own way of data presentation. Can we show that that clinicians who get different pghd from different types of wearable platforms understand all the reports? Or should clinicians limit patients to use one specific brand of wearables that they are familiar with, which might be impossible, and clinicians themselves prefer giving patients authorities on choosing their favorite devices. But they're also concerned that over time, the people use different tools. They would expect clinicians help them in interpreting the report, while clinicians can't cope with these changes. The second is integration with EMRs, but if happens, would change lots of things. pghd could be captured from any type devices, but be filtered, cleaned, and analyzed to extract meaningful information for shared decision making. The third item, which is still challenging even for clinical data. So if pghd would be considered as a valuable source for patient care, should be treated similarly. And we need to think about consistent exchange of this data as well. Interpretability and consistency concepts have lots of overlaps. This item was the most dominant issue reflected in all of the 5 studies. The patient-clinician interaction will become less about gathering pghd and more about interpreting what the pghd means for the care of that individual in the context of their life. First, all pghd lack metadata or contextual data to inform the clinician what the patient was doing at the moment of data collection that caused the up or down in the trends. Also, some devices enable the patient to take some notes, but it would be better to capture them in a more systematic way through interaction with the patient. Also, only few wearables give alarms on the out of range data. Not all of the patients are highly literate to understand the out of normal range for heart rate, for example, and what would happen for them if that occurs. A clinical advice can be attached to the alarm to improve patients' awareness. Additionally, most current wearables provide a snapshot as a PDF and maybe show interactive visualization through patient portal, but only to the patient and not to the clinician. But clinicians might need to go deeply through the reports, customize it, and do some functions. Okay. So the completeness, the main reason for repeating data collection is incomplete data in the report. Sometimes the device doesn't work properly. Sometimes the patient take it off and because of lack of motivation or because of being a burden or so many other issues. But what can we do to avoid it? If there would be a predefined protocol to specify some downtimes during a day based on clinical standards, and then resuming data collection to make sure that sufficient data could be collected to make a decision based on. Also, annotation functionality that I mentioned in the accuracy slide would help to report on the reason for missing data to find out a solution for it. Apparently, all data relevancy doesn't need more explanations, but the finding showed some relevant data are not yet defined in the wearable design. Also, not all the captured data are relevant to the clinicians. So clinicians have to spend time to find out the most important information through the reports. So going back to the point I addressed at the beginning of the presentation, that different people look at data quality differently. Some might focus on the review stage and try to design some dashboards when pghd from different tools come together and filtered and analyzed there. Some would bring equality to the collection point. There is another, this is actually another snapshot to show which aspects require more consideration during each stage of pghd management. As pghd is collected outside the clinical setting, under the patient or caregiver supervision, it needs more concentration in terms of quality assurance. Similarly, some issues exist at the clinician side or during data transmission. Okay, the limited time of the PhD didn't allow me to go further. Also, this is the end of this PhD, is the start point of too many other projects. The refined guideline needs to be implemented in different remote patient monitoring settings to find out more details for each disease. Moreover, each of the 7 aspects can be studied separately to identify more socio-technical issues and create models for redesigning the wearables or creating new care models in remote patient monitoring. What you can take from this project, the guideline by itself wouldn't be efficient if none of these 4 elements exist. While remote patient monitoring certainly has value to offer to healthcare system, there are multiple obstacles to consider and overcome to get the most benefit out of these technologies. More policies are needed in terms of reimbursement models, human resources to expand the remote monitoring team, more regulations, especially for consumer wearables, are needed. Also, a robust technical infrastructure to seamlessly incorporate this data into clinical workflows required. Also, PGHD stakeholders, not only patients and clinicians, need digital health literacy And the last but not least is the collaboration. Remote patient monitorings mostly work in silos. Different groups of stakeholders don't communicate with each other to understand the needs and the requirements. So we need to consider all of these to make sure that high quality pghd is collected and used and managed in different remote monitorings for connection to healthcare system. These are my achievements through the 5 studies that I showed earlier in the methodology slide. I was quite happy to be able to present in international conferences. There are some more publications on their way that haven't yet been published. And yeah, I really thank all the bodies who helped me with grants to travel and to register in conferences and to publish in some journals. Acknowledgement time. I thank my lovely advisory team who not only supervised my PhD, but also helped in so many different aspects of my life. We met every single week during these years since 2017, and they kindly and enthusiastically tracked my progress. I also thank all the friends and colleagues in the Center for Digital Transformation of Health, as well as the Department of General Practice, friends in other schools and faculties. Thanks to the University of Melbourne for offering me the postgraduate research and training scholarship to help me survive these years. Also, special thanks to the Australasian Institute of Digital Health, who've been with me since the beginning of this journey and had significant contribution to my success through the fellowship by training program, as well as other positions and activities. Friends and folks at CSIRO who also supported me in different stages of the project. And thanks to friends of folks in other institutes outside Australia. And a big thank to all of you who spent your lunchtime with us today to watch this presentation. Hope you enjoyed it. And this is my last slide. So before we go through the questions, Dawn, if I'd like to hand over to my advisory team if they wish to say something. Thank you.
Robert.
Wonderful job, Robab. Very well done. Very proud of you. Congratulations.
Congratulations, Robab. Fantastic talk, and you've covered everything that we anticipated and more. And you've been a very considered and powerful researcher and colleague.
Thank you very much.
Well done, Robab. Cheering you on. One day I'll get you in the ocean with me, but in the meantime, this was a fantastic presentation, great visuals, and really serious implications for where health goes next. So thank you for delivering that so well.
Thank you. Thanks very much. And Dougie, if he wants to say anything.
Yeah, indeed, congratulations, Robab. I mean, obviously I've been on the advisory committee, seeing you as you've gone through your thesis here, and there's one thing that you're very organised, and it's been a real pleasure to see your progress throughout, and yeah, this is absolutely fantastic, so best of luck to you. Fantastic.
Thank you. I really need a walk like this cat after this presentation. Are there any questions in here? Can I see the...
While you're having a look at... Oh, sorry, after you.
Oh, so no, you go first, Frank.
No worries. Just interested in the guidelines, if they consider the accuracy of the devices, as far as clinicians looking at results may assume that the values they're getting are akin to what they might have for full medical monitoring equipment in a hospital, and then the devices may not be that accurate. Is there anything in the guideline around potentially baselining a patient with these wearable and other devices that are capturing information that may not be of the quality of a full hospital grade device?
Yeah, that's a great question. Thanks, Frank, for that. Actually, the guidelines, as a kind of generic tool, just to provide, some more information to tell us what's going on in remote monitoring. And if we want to look at the accuracy, these are the issues that we need to consider. I only brought the key things in these presentations, but there are absolutely much more details, to give some directions on other, technical guidelines about the accuracies, addressing some policies developed by, regulatory agencies like FDA or TGA here, to say that how people need to collaborate with each other to implement those and work on those. It's not always something to hear from the wearable vendors and do it. They also need to hear from clinicians and to get feedback from patients as well.
Yeah, that's very valuable. Thank you.
Thanks.
Yeah, I was just wanting to know what's next for you, Robab, and for you and for your research. Because certainly to get your research for this stage, I'll talk a little bit so you can think about what you can say. But certainly for your research, there's huge potential for this, and I think anything that we can do to get it into the arms of people who do the startups. We're also doing some work in the standards community, and if that progresses, this stuff really fits in there as well. So yeah, just a few ideas. What do you think for your research? And then yeah, I'd be interested to know, if you don't mind, anything you've got to say about what's next for you.
Thank you very much, Louise. Yeah, as I mentioned, what's happening? As I already said,
Paul might need to mute his mic. Paul Cooper, yeah.
Oh, okay, thank you. The next step is to work on this to implement it. As I said, this really need to be implemented in current remote monitoring, programs, as we still don't have any project working on integrating this into EMR systems. So the next stage would be putting this guidelines somewhere in a project that tries to work on integrating pghd clinical workflows and identify much more gaps in that. I'm really interested in finding, grants somewhere, working with some people who are trying to work further on mobile health data, and not just limited, to small mobile health projects, but thinking about bringing this to routine clinical practices. And we have here in Australia CSIRO, Dr. Mohan Karunanidhi, who is really doing a great job in this space. But it depends on the purpose. Some people just run remote monitoring with a clinical purpose, and that's it. But if we think about it from digital health and health informatics point of view, and what's the purpose of using this data in clinical care, and what's the purpose of integrating, then we can think about the technical, interoperability issues, all sort of socio-technical issues, which I couldn't actually find at the moment, except for CSIRO. We still are excited about seeing technologies coming in the market and running remote monitoring. But this study actually goes a bit further to evaluate remote monitoring in terms of, the quality issues. So when I sometimes talk with people and they say, oh, look, we have, these devices are remote monitoring. I said, look, how about the quality? People still not, most of them not still thinking about the quality in that sort of things. And quality, unfortunately, is still, people look at it as a kind of, traditional task that health information management professionals do for the paper-based medical record. Even for EHR data, still we need, much more guidelines that specifically focus on that kind of electronic data. So now we're getting another source of data, which is pghd, without, thinking about that one. So I would be really interested in those people who are trying to work in this remote monitoring, any kind of mobile health projects, to think about the quality as well.
Thank you.
Robert, congratulations. I
Thanks,
think
Graham.
your timing is perfect. COVID-19 has displayed the inadequacy of most health systems, remote monitoring and patient care arrangements outside of the hospital. And most of them are now rapidly trying to play catch up for patient monitoring at home to help reduce their dependence on inpatient care. So I think that there probably will be a lot more scope for you to work with health systems in real time now than there was 3 years ago. I think you're just a little bit ahead of your time in some ways. But on the other hand, now that you've done all that work as a grounding point, I think your value to the health system will be quite high.
Yeah, thanks, Graham. I just, wanted to highlight the point of seeing where digital health is here in these programs, how health informaticians, where they are. As I said, they are not actually in the team. Also, I interviewed some of them just to see what would they think for the future if they will be involved. And imagine if pghd would be incorporated into routine practice, there would be much more new roles for these people, because it's not always, needing, the vendors, a representative from the vendors, telling the clinicians what to do or fixing some technical issues. This is a socio-technical approach, and as one of my stages in this PhD was co-design workshop, which I mentioned it as a limitation because I did only one, because I couldn't actually talk with all people around the world, about remote patient monitoring. So, and also I mentioned in the interview study that it was really difficult to find people. Even health informaticians in the hospital couldn't help with these. So these gaps, can be filled when we go further with these studies, and can define some role for digital health professionals in this specific.
Sure. Well, I think that a lot of the clinicians in the hospitals are now very interested in how they can use remote monitoring for heart failure, COPD, diabetes management, and other chronic disease. They don't have the expertise in general, and even incorporating some of this data back into the EMR, how it's displayed as distinct from other observations that are being generated by hospital staff in the hospital, and how the MARTA and other regulatory authorities see some of this content and provide some barriers to how it's actually used and displayed in the EMR. It's all going to be very tricky.
Absolutely, yeah. Yes, Lucky.
We've got a few GPs in the conference as well. I'm interested to see whether your presentation today is inspired any of our GP colleagues, that if we've got quality information coming through, are there any sort of number one, number two things you would want to do with data like that? Yeah, Richard.
Yes, thanks, Doug. Very wonderful presentation. Thanks for that. And certainly an area that's been rattling around in EMR records for decades, honestly. The interoperability of data, even the interoperability between Medical Director and Tracksoft and ZMed and this and that, and My Health Record, which is a flat file system that doesn't integrate at all, except as just files we need to read. So there's a lot of issues regarding this interoperability and the ability to make sure the data has integrity, as you say, with those steps, the accuracy, those 7 items in the guidelines. I think if they were present 20 years ago, it would have changed the way that the EHRs would have developed from that point on. because they do address all the issues that we face every day with a system that's been cobbled together, essentially. So we do have flat file data, we do have data that is actually able to be accessed and then collated. And one of the projects we're working on at the moment with Future Health Today is looking at how the EMR data can be accessed, how it can be analysed, and how it can be used purposefully for research and implementation to implementation of patient care, like in cancer diagnosis or chronic kidney disease, particularly as the main focus at the moment. So my comment is to do with it's a great idea, and if that could be broadened across a wider scope of interoperability, so looking at future projects, saying, well, this is a really good grounding, it's a very good set of guidelines, and making sure that that's implemented across other health information systems, like through ISA and things like that, where we're looking at health interoperability all the time. So in order to get that data clean enough, accurate enough, appropriate enough and interpretable to make actually something clinically useful, there's going to be a whole world around that where people say, is it accurate? And we don't want to be in the position as GPs as making decisions based on data that's not accurate or not clean or has so many obfuscating variables we can't even be bothered using it. So I think great idea in notion, but the pointy end of it being accurate and consistent and reliable, all that's a long way off, I think. I'm a bit of a pessimist, as you can tell, but I think it's a really great start, and I wish that more people knew about it. So I hope that's helpful, but I do appreciate what the work you've done. I think it's got a lot of implications, so thank you.
Yeah, thank you very much for the great point. And this is where innovation comes from, just to try doing something differently, and I just wanted to define data quality management in different ways for this specific source of data that, we always talk about the quality, I always see in reports, in white papers, in conferences, but I would wonder, what do we really mean by it and where we go, by this. So as you said, I really look at it, as a start point for too many others, if they want even to focus on specific aspects of that quality. Yeah, thank you.
Yeah, Joanne, have you got any thoughts on what would be your number one if we could quality sorted out? What would you want to see in front of you with the patient?
I think that the main thing is that there's not data overload, and it's quality data that's actually actionable. Because otherwise, if there's so much data coming in regardless of its quality, much of which you might not necessarily need to make any decisions, it could end up being less helpful in a way. But on the other side, it's interesting to see that the example that you start off with, Robab, about the person with type 1 diabetes and all the different devices, that some people with that condition have actually just said, well, stuff it, I'm not waiting for health professionals to work out how to share my data. We'll just create our own community and we'll work it out ourselves, and they have. So I think it's really interesting to think about, putting all these guidelines and principles in that are important and very well needed, but that sometimes communities of people will come together and just say, we're just going to get stuff done and make it work for us. So it's really interesting kind of contrast.
Yeah.
Exactly, Joan, because, people need expectations, and there are some, worldwide surveys, run by Ipsos around, I think, 28,000 health consumers around the world to ask them, whether they want their clinicians to have a look. And most people would really love to get clinical advice, but sometimes they're just disappointed because clinicians are not motivated. And when we ask the clinicians that why they don't want to look at it, all issues around the quality would come across, as well as other issues like they're not getting reimbursed for the time they spend, or there's just too much data that they don't understand it, you know. And any other things across the healthcare system that when I mentioned the policies, you know, need to be in place to improve this interaction and this communication, you know, between clinicians and people. That's why all the remote monitorings that we have are, you know, clinician driven. But when people want to bring data from consumer devices, clinicians won't, you know, look at those data. So that might be one of the reasons for people just to limit it for self-management, self-care.
Yeah, this is why I'm really interested in the annotation part of what was in the presentation, because to me it's not necessarily just about masses of data going down the line, but it more is what's the significance to the patient, and is there any information that, you know, the patient's actually thinking, you know, I'm really worried about this, you know, so there are the triggers here where you're actually needing information. So communication is one of the key things here, and not necessarily just the results data there. It's actually communication of the significance to the patient, and whether you know, there's a trigger then that means that the health professional really might want to look at something.
Exactly. Yeah. Great.
On that point, thank you, Doug. That's a very important point about, Joe mentioned that patients are taking things into their own hands, but in doing that, there's also that risk of aberrations in the way the group functions. There might be good groups and bad groups and dysfunctional groups and even Zoom-bombed groups or something, whatever. So having a patient who's got a good health literacy, I think, was one of the points that you made, Rabab. And this makes a big difference. An intelligent patient who's involved in the healthcare is actually an enormous boon to the doctor-patient relationship. And anything that fosters that, and anything that produces an interoperable communication, as you mentioned, Doug, that makes work so much easier. You've got a colleague inside your patient. You've got a version of yourself that can actually interrelate with that patient at a much better level. And that's magic in general practice land. Thank you.
Absolutely. Yeah. And thanks for all the congratulations on the chat box in here. Thanks, everybody. Any other question? Any other comments you like to add? And also, Wendy has added something about the Validitron here. Wendy, do you want to say anything?
Wendy's gone.
Oh, it's gone. Okay, that's fine.
I think it's nearly time for a number of other people to move to their next Zoom meeting of the day, but under other circumstances, we'd be inviting everyone to University House for a great big celebration. So hold that thought, because we'll do it when we can.
Of course, of course.
Okay.
That'll be wonderful. Cheers.
Okay. Well
Thanks,
done, Robab.
everybody. Thank
Well
you.
done, Robab.
Thanks
Well
so
done.
much.
Very much. Bye-bye.
Thank
Bye-bye.
you. Have a great day. Thanks.
And you.
It's fantastic. Take care, Robab.
Thanks,
You
Robab.
too. Thanks. Thanks, Dawn. Thanks, Claudia.